I know it may not very often at the faculty level, I think, right? So that always helps. And I was telling your teacher is I learned from neurosurgeons. When I joined first in Halifax, Dr. Rob Brownstone, the functional neurosurgeon, he told me that you do research. I said, yeah, 20% protected time. He said, well, make sure you keep that 20%. I said, what do you mean by that? He said 20% gets eaten up, administrative work, very easily. And before you realize, it's gone. So make sure that you have remains 20%. And I think it's been my important because it's like we feel that research is not work, which is not true. So one of the way I look at that patient today, you are affecting one person's life. But if you do a research, you could potentially affect people at the same across the world. Talk about some of that today, how we can do that. And so this is one way of looking at clinical research, not lab. This is all research, clinical data, and to the patient, back to the. So how do we talk to the patient in your clinic? Is this a patient comes to for the heck of talking. So if you have a patient, you tell them, okay, I can do that. And this is, and I'm pretty sure some people do that. But we tell them, okay, what happens if you don't get any treatment? What's the natural history? And where does from the books? Who wrote the books? Somebody in North America or Europe, somebody wrote that book. You get that? That like I went from India to Canada, worked there, and our approach to the patient, the natural history is so different there. A colleague came back and we talked. Okay, so how much heparin, like as simple this, how much heparin do you give for cancer? I think we know. Hey man, how are you? Here, I didn't realize.
He's a friend of us. Only neuro.
Yeah, we were in Nimas together.
Yes. That is what he was telling that together.
Must be in that meeting the research was talking about that. They showed and they said, okay, this is the apple tree under which this. So anyhow, so I put in those diagnostic angiogram. How much it would give? Sorry, 1,000. One single dose. So we give 0.
We don't. I mean, for SH, we don't give. But for stroke patients.
So for whatever for diagnostic angiogram.
No, I'm talking about diagnostics.
For just a normal patients come with some kind of vascular problem and out on an outpatient diagnostic angiogram, how much heparin do we give? We give none.
No, it depends. If you do radial, to give.
Yeah, radial is different. Radial is very different. That's correct. But what I was trying to say is because the patient here there is all of our patient population has slightly higher thrombogenicity. So data from North America does not our patient population here in India. So as simple as that, what is the complication of don't give any 1,000 units of heparin versus 5,000 units of heparin. Here is another big research paper. Do you have to go anywhere for that? No, that's simple, as simple as that. Observational study for resident level. This is such an important do. Like this is just the one example, and we were talking about more pretty much like where and how many patients you guys have versus how many we have. And you guys have 10, if not 100 times more population itself. You guys have all of that. Key is like the follow-ups. We have almost 100%. Those patients don't necessarily, and like medical system followed more kind of American medical system because patients have whatever they want. Canadian medical system is slightly different. It's a universal healthcare, so you have to go to the same place. You don't have an option only when that doctor will tell you that sorry, we don't treat you, so we'll refer you to someone else. So that has advantage and disadvantage at the same time. But for the research purposes, like we are our own randomized controlled trial for embolization of middle meningeal artery, and we have one patient lost to follow up out of 200 patients. Lost to follow up. Compared to all the American trials, they have 22 lost to follow up. And the newer data that they just presented in ISC, the International Stroke Congress in February, they got 50% loss. So come on, guys. 50% loss to follow up. And these, that's value, but they will publish it. That will get published. So if they can publish loss to follow up, I can't you. So just be honest to it. Just say that 20% patients. Nothing wrong. Other part of the world don't have 100% follow up either. Nothing wrong with that. So the data that you need for Indian population do not have. Books are written by somebody who do not know how the Indian body behaves. So for you, sir, like maybe different, slightly different from Indian leader as well. You need your own data. Embolization also in Nepal is just beginning. We are wondering whether this would require so we do easy and are we able to well, we'll talk about that more. I was part of one of the is that time?
Yeah.
We'll be going live.
Okay,
Yeah,
sure, yeah.
we can go like
Yeah.
Maybe we'll just start here. We'll just informal discussion,
Yeah.
waiting for you.
because people are saying exactly waiting for you. And
Study. Okay. Numerous briefly touching few of them. He has been the president of the Canadian Neuro Group. He's on board of the Canadian Radiology Journal, scientific co-chair and Canadian Society of Neuro-Radiology, as well as on board the SAPM Monitor. Just briefly going back, roots come from India itself. So for all of us, sky's the limit. Sir has done his basic training medicine from RIMS ranching to in Banga. Then did his DM Neuro-Radiology from the prestigious Nimhan Institute. Continued self-interest has patient, as I was earlier discussing, the patient-driven management. So he continued. He did not stop there. Continued MSc in the vascular studies, of fellowships to his credit, as well as that he went into epidemiology of the patient to come to better treatment. There's so many honors to his credit. Just briefly to touch them, the latest being the doctor's Manitoba Award, the Honor Your Hero Group Award in 2020. Young investigator has been right from the beginning into investigation. You has not stopped there. Prize or I'm not worried because we want to listen to him. We are not for us. This was just a brief introduction. Request sir to just share his thoughts. Thank you. Please.
Thank you so much.
Go through my own CV.
Just connect from here. Yeah. Particular study. So you see how we done differently. I didn't put that like I wasn't aware of this background happening here. So I should have added one more piece of information here that I helped you guys, and I will actually take a break from these slides with others another because that's how we started this study. I think it will be good to know that. We're good. Okay, so we are going to talk about embolization of middle meningeal artery because it's easier to pronounce. And you don't know how to say something, you cannot convey this very easily. That EVT for endovascular has made it easier to convey not on ourselves but also to the patient. Similarly, we don't have to spell out the embolization of middle meningeal artery or middle meningeal artery embolization. That's say. So we started to call it EMA just so current evidence and path forward. We'll just very brief. I am particularly for this topic because the study was funded by Medtronic Canada. Funded. There is a different way. Embolized trial, which is not funded but funded by Medtronic. What that means is the patient data, patient analysis in the manuscript results where it should get every single thing was decided by Medtronic for those studies. Whereas in our study, they were at arm's length. They got every few months, and no involvement in the trial. So that's the difference. So, but still we have to acknowledge them because without that funding, we couldn't have done this to ourselves. So we are going to review the natural history of chronic subdural. I think we talked about the natural history, saying that we don't see the records, see it. Okay. This is what we believe. And we'll talk about the EMA. We do it, how do I do it kind of thing, and review the results of other trials and trial and evidence beyond the randomized control trial and future of that. The chronic subdural, everybody knows this, right? You know, where is the hematoma in this picture? Somebody first year. Right. Okay. Acute versus chronic versus acute on chronic. Subacute. This basically. Acute. Acute. So this could hematoma. It could also be something like chronic. But like we used to learn about not acute on hematomas. Most terminologies we have changed now. We just call it either hematoma or not because the natural history of these hematomas are different, and acute and chronic belong to the same as chronic subdural hematomas. Calling them non-acute hematoma, convenience sake, we continue to call it chronic. So it could be or could very well be bilateral. Okay? We all know this, nothing new. What is important here is incidence increases with more common in men than women. We don't know why. I think men bang their head on the wall as often as this joke. Okay. Still men common circulating than women. Incidence increases with age. Incidence, there is another we know very well. There also the incidence increases by the rate of increase of the incidence is much higher than that of the ischemic stroke. This is our, again, back to the same thing. Just remember, this is our own data. In Winnipeg, patients with subdural here. This is what I was talking about. Small thing, pick one thing and publish your own data. I continue to refer to that. This is study accepted for publication in JAMA. I'm not supposed to say that. I didn't say that. But we first in the index reference section, first paper that was quoted was this study, which is like a small study, but this is our own data. Very important to emphasize how important is your own data. Okay, so how big? Because everybody is getting older, we have older population, the incidence is going to increase, and this is the most common neurosurgical condition that is being dealt with. So it's not uncommon, and I'm pretty sure the first year residents are busy putting burr holes in these patients, correct? So that happens, and it's very important why this to put into the perspective that the first year residents are doing this. Holes, who is doing it? Thing that you get to learn when you start this residency. So it's also low key surgery, right? So I have done burr hole in my neuro-radiology training and the neurosurgery rotation 6 months in burr holes as well. So it's common disease being done by the learners, much more common, more experts. That's what is happening. So surgical treatment common, and it is staying now, burr hole surgery or maybe craniotomy. How many of you do you do here? You do?
Yeah, we were doing during COVID.
Okay, during the COVID. See, so you can publish your own data. How many drill versus others? Come on, like you must have done thousands. So these are like few ideas for data observational studies. The challenge, some people can say that we don't have recurrence, but tell me honestly, how religious these patients? What is your protocol for these patients? And this is not talking about this Indian. Yes, we had a Canadian neurosurgery in 2022, and our room in neurosurgeon from the part of Canada has the same question. How often do you how many follow up after birth? And as half of the we don't follow up. If the patient will have recurrence, they will come and show. Now, this is the reality. If you don't look for it, it doesn't exist. So when we say that recurrence is only 2, 1 or so or 7, is because we haven't followed patients. I'm going to show you our own data, like where we have religiously followed these patients. What is based on that? Majority of recurrence happens within the first couple of months of first presentation. Would be the reason. Like in bilateral, we can use of anticoagulation because if the patient is on anticoagulation, it have a higher chance of recurrence. And repeat surgery in these older patients, most patients don't even agree to have repeat surgery. Oh, short दीजिए रहने दीजिए चलता है, right? Does it happen?
No, the biggest problem is
neurocephalus happens.
biggest problem.
Immediately after surgery. But that's not, we're not talking about that. that is the problem with the surgery. That's what we are talking about, the natural history of the disease. The disease coming back. Remember, like most you have your 80-year-old household, right? How many times have you seen them seeking medical? Oh, सिर में दर्द है. They feel it. Is that not the usual thing? That's what we do. And that is the reality. So the is we don't see recurrences because either the patient don't show or we don't seek out those both sides. So cost analysis, there's a study from showed that cost of repeat surgery is much higher than the primary surgery. So those are recurrence, and I'm just quoting continue our own recurrence rate, which we collected for of our randomized control. Our local data. We published this as well. 22.5%, which is roughly 1 in 5, right? So now let's settle this. How do we define recurrence? Or somebody can say one is symptomatic recurrence, same symptoms. But that only you can think of unilateral subdural hematoma on the left side, patient may be coming with aphasia, but that doesn't really happen lateral subdural, right? And the 1/5 of these patients, as you can know, could be bilateral. How do you decide symptomatic recurrence in those? Very true. So one thing solve this like this is there's no bias is radiographic recurrence. We define radiographic. So you know this is the interval evolution of the hematoma is 7 day 11. What happens at the beginning? The hematoma will be dense and it will slowly become. By day 11, it's okay to have some hyper. But I show you the same hyperdensity at day 30, or for a matter of fact, day 9. You agree that natural evolution of the no, that was a new breed. So if you agree with this, our criteria for column recurrence. Criteria for radiographic recurrence is either increase in diameter last scan. Last scan is tricky. As you rightly pointed out, what about pneumocephalus? For our CT, where is the hematoma of the hematoma? It becomes tricky. This is not this is just the of the beast here, right? So either increase in diameter when you have a proper CT scan, which is in that is recurrence criteria, which is at least 10 millimeter in thickness in axial with acute blood. Also, if there is an acute blood, you know there is an acute blood. We all the small acute blood, we never can millimeter thickness. And we know that because it's not really significant, not want that to be included. We wanted it to be at least 10 millimeter thick. Because that's the kind of criteria of those patients. Right? So this is our definition of radiographic recurrence. Any debate on this? Okay. Okay, so what's new now? Now that there is recurrence, we don't know what is the recurrence. I showed you our own data. The new part in chronic subdural hematoma is the inflammatory hypothesis, which is not new. Volko described that back as leptitis, like meningitis or something. That's what he called it, hematoma. So he knew that there's inflammatory component. We've been knowing this for a long time. Randomized control trial on which kind of helped in reducing the rate of recurrence. Stop more 30% rate of complications. So can't give patient. Remember, these patients are older. They have other comorbidity like diabetes with steroid use. So you can't give them the complications. So now they settle down 2017 when they described the full pathway of inflammatory pathway of the chronic subdural hematoma. So what it simply means is there is inflammation. Inflammation causes neovascularity, and neovascularity causes hemorrhage and re-infection. And what we are trying to do is address the neovascularity by doing In other words, this is a cartoon diagram I created some time back. This is the subdural hematoma. We get into the middle meningeal artery using a microcatheter and use the embolic agent. Applies the middle meningeal artery. What happens over time is both the hematoma as well as artery size. That's what we want to do. Pretty simple one case. How do I do it? So this is a student with any guess this patient based on the CTs. Anyway, why? Sorry. Okay. Anybody else? Yeah. Just give me one more guess. Is 15-year-old. Okay. So I put this picture because this patient I treated with embolization in my 15-year-old, he had a small arachnoid cyst in the vertebral fossa. And if that was nobody presented with word finding subtle weakness of. Okay. So also had this brain-like structure you can see on the CT scan. Patient was with large craniotomy and still, and we followed upon this patient. We also do CT. Some CT angiogram is twofold. One is these are usually old. We want to know whether we can get into the middle meningeal artery or not. To get, so we need the access and pulse CT angiogram. And we have learned how to identify the abnormal communication stomach artery meningeal artery CTA. So on the axial images, you will be able to see those abnormal communication. So dangerous elastomer. So we can identify those now. Probably some couple of years back. So for reasons we do these patients. So how do we do this? So we inject it out to first, and we do not go it out. The reason is we don't want to be selective into internal carotid artery. These patients are older patients, some kind of plaque at the bifurcation. So you don't want to get into trouble for unnecessarily. So common carotid angiogram and the external selective angiogram, and this is your you can see, and then we select usually the posterior image and go with the microcatheter, the tip of the microcatheter, and then we do the microcatheter onyx from there. They say onyx, but we do use as well. So in any of the so we inject from the wedged position of the microcatheter. Immediately after the embolization, you see the posterior division is gone, anterior division still exists, and then we go selectively into anterior embolization. Stumps are there, and then we do artery angiogram again to make sure the optimal coronary flush with the eyeball is still exists, and we have the microcatheter should be in the rest position. And if 3D angiogram afterwards, you'll see the distribution of onyx cast like this, onyx or split cast. Actually, split valve that we use in this case, we will be able to see how the distribution of the quality. This is a follow-up patient inhabitants. Okay, so some been published in the last 1 year. Embolize stem, and there's no about these trials. It's not good. I color coded them. Embolize and means when we largely it reduces the risk of it. Whereas the magic protect were neutral, and magic onyx, squid, and protect used particles, microparticles. So microparticles show that there's no significant versus non-embolization. Now we have 4 guys, 2 positive, 2 neutral. We need a type. Okay? So we look. I published this some time back just to analyze the data, early data. And what is important is if you put the you look patient agility. Did is added some of the patients where they use the primary treatment versus MI. So you cannot compare because one second treatment, where the other is treatment becomes tricky. So if you get the data between the two, it becomes slow, muddy. Let's take one. So it was not positive. And if you put all the so Emma can trial. And I'm going to switch. So history of Genesis, little bit of history, and this is history. 2020, the going on stem and embolize in Canada, and they say, "Oh, I want to go to Canada." So, okay, in June going point action, and life gives you, right? So that's the lesson we had. So in July, our own systematic review, and we published size calculation. And September, we got the results of the review. September 2020, we grant to get the funding, got the grant, CIHR, there is ICMR, Indian, so that's that equivalent to that, or NIH equivalent in US, Canadian. See, 20 we took already for the trial. October 2020, we had the grant to Medtronic. So look at the you have passionate about something after that, right? What very and because we also wanted to compete with the other trial, but we don't want one to, which we ended up the silver lining there with Rob. And we had the for in November we had the full mission in but that was the first that I showed you that already in December 2020. So we started planning for the research without actually kids because we wanted it from the upfront. And so July to December 2020, we started the team across Canada, different centers, how we do it, who all want to be part of this study. So 6 months from the time we initially conceptualized the study, we got the funding. Just confirmation that they will fund, and then we started the process. June 2021, contract was signed with, and July 2020 started the database, and August 31st study. And this as you can see, that's not required. So I just wanted to show you that if you want to be passionate about something, you talk to that and you can get things done. When you want something to happen, dialogue. किसी चीज को आप शिद्दत से चाहते हैं तो सारी आ जाती something of that. I say that very well. That does happen. Okay, so Emma can study very quickly. Research question was, is Emma adjunct to surgical readiness? So we want very our patient population. We wanted only patients where surgery is already done. So that's the natural history data we had. 2.5% rate of our own setups. So associated with reduced rate of recurrence at 90 days. So this is our study. So we look for patients who have limited thickness of subdural hematoma is going for surgery. So if the patient is going for surgery, those patients, we and after surgery was very important. This is unique about our study. After surgery was then only we randomize the patient into the trial between the EMA arm and no EMA arm. So you guys are neurosurgeons, some of you very experienced. Will it approach if you know that this patient is going to get after the surgery or not? Will it change your no? Okay. There you go. I'm sorry. There's like you can see the like both of you guys. Yes, one is saying yes. Effect. So at least 50% neurosurgeon can get by that the patient is going to get EMA or not. And remember, this is randomized. If you look at the methodology, the key. So you want your neurosurgeon whether you get a or not, that's fine, but you should be blinded. So this is how this was the only study where surgeons were blinded to the randomization. I followed these patients for 3 months. At 3 months, we follow CT scan. If control out, the patient received standard of care. Only thing that we did not allow is no use of dexamethasone or high dose of oxalic acid. If the thinking that they want to use it, we did not include those patients in the trial. And in the interventional arm, what we did was within 72 hours of the surgery, we did the embolization. And we used onyx 18 simply because the topic. And this is the grading scale we have published like 4 or 5 years back now. And we encouraged everybody to grade 2 or grade 3 embolization, which means complete embolization of the Middle Meningeal Artery. Here are the results. 519 patients screened, 192 enrolled, 1:1 embolization, 98 in the MR, 94 in low MR. These some patients, 9 patients and 93 patients in both arms underwent final analysis. So, what was the primary outcome at 90 days? So this is the control arm, 28% recurrent. This is symptomatic recurrence confirmed on the CT scan. 28%. And patient arm, 3% symptomatic. What that means is there was 6.4 increase of recurrence of chronic subdural hematoma when embolization was done. If you understand it, number needs to store. So I hope you are not. So that's so this is how effective it. Imagine only four patients. Broaden this horizon a little bit more. What about the radiographic? I showed you the definition for recurrence. If you look at the control arm, roughly half of the patient have the radiographic recurrence. Why do we not know? Or we don't believe? These are the patients where every patient follow-up scan done within that 90 days window. So 90 days wasn't 90 days as such, it was from 60 to 120 days that main work. So roughly 50% patient had some kind of recurrence. Remember, of those were symptomatic. You see, 14% still recurred, and only 4% recurred symptomatic. So also the which reported both radiographic recurrence. So now, for radiographic recurrence, there was 3.5-fold reduction, which was less, but still okay. Number needed to treat was 2.8. And I feel it is very important to radiographic recurrence. Although someone can say, hey, it doesn't matter. I agree. I'm not disagreeing with that part because nobody just because of the blood. Patient, but imagine those bilateral hematomas. How do you recognize? Symptomatic? Well, it becomes tricky. Which side is well? You operate on which side will become so it becomes tricky. So an unbiased test, which will be a CT bus side, serious at 90 days, slightly higher on the MR arm, but it was not significantly statistically. And none of those actually affected the MR procedure. Remember, these patients are old, they do die without their from other things, they have other comorbidities adverse event, but none of those were from the MR procedure itself. So on this is RCT, we were very picky about in the RCT. Beyond, so we ran a registry. The patient is coming to our hospital. We first screen them in the randomized control trial. But if the patient is not eligible for randomized control trial, we put them into the registry. So we did we like a couple months back, National Stroke Congress in February. So this is the first published consecutive patients from real world scenario concurrent to the RCT. Most of the patients were not eligible for RCT. The majority, roughly 50%, were bilateral subdural hematoma and asymptomatic hematoma. Many of them had significant medical comorbidity because of which the patient was cancer, okay, and hence had contraindication to surgery. So remember that this table you remember from before, and this is the prospective registry where patients enrolled. Reasons explained there. Only 93 patients we could use for the final analysis. 3 patients with 140. So majority of those were bilateral situations. I'm going to radiographic recurrence because half of them were. So remember RCT, 50% patients recurred on imaging, only 14% MR. If you look at the patient level data, 21.5% recurred, so slightly higher than the randomized control trial. Is still 3.6. For the if you look at the image of these patients had bilateral subdural hematoma, this is very similar to what we saw in control trial. Only this is 14% recurrence, 16.2%, very close. So hematoma level very close to randomized. Again, very close to randomized control trial. For bilateral subdural, look at level, the recurrence was much higher. All these patients have risk of 2 times. But if you look at the hematoma level, this is see. Okay, and adverse event. As expected, these patients have comorbidity because with some of them were not even surgical candidate. So SAEs were higher, mortality was higher. So mortality was, but SAEs were associated procedure itself. Okay, so this exists. What about how do we want to go deep? We want to make it more accessible to us are not comfortable. Particles, we already saw that trial. So particles we're using right now. So other possibility is coils. So try coils, but most of those coil studies have been like coiling and which is not what we want. We want as distal as possible, west position. This is the study we use now. Actually, we have patients and all, and this is how we do the tip of the microcatheter. This is the coil we use, and the coil, and then when you do this, you will have some picture like something like this. You have a very distal occlusion of the middle meningeal artery. I don't know whether this will work or not. Know that, but we hopefully in a couple of years we'll have the report analysis and we'll answer. The other possibility for Emma is used and a little bit controversial. This is starting up, and we are in the process of trial. And so migraine is common. So secondly, majority of these patients are not like chronic subdural hematoma. These are young patients, very active, and they are debilitated by this medically refractory migraine. And some of them actually can help with them. These are preliminary data. How none of these are very clear to us. Pathophysiology, how it works. What we know is the artery does something, and by blocking the MMA, we the release of the migraine causing substances, whatever that is, don't know very clearly. So lowers the sensitivity of pain to fibers attached to the vessels of the in the trigeminal bed. It's likely to work. And there are more trials on the way. We are starting our own study as well, so we'll know that. So that's so we kind of Emma as an adjunct to surgical drainage for unilateral chronic subdural hematoma lowers the odds of both symptomatic radiographic recurrence and our study the effect size so far to treat out few neurosurgical surgical has number needed to treat. Do you know which one has better number needed to treat? Neurosurgical, which you do, has number needed to treat of 1 to become before them. The number needed is 2. Outcome is not on that. You guys just saw epilepsy surgery. If you focus, go in and take it is to 1 to 2. Amazing. So have something done here. So how can you not offer the patient? Emma reduces the rate of both in patients in trial and your scenario, as I showed you. The patient who had or without surgery, unilateral, SAE were similar in the randomized control trial. Registry for obvious reasons because these were sicker patients with bilateral symptoms. Many of those were eligible for surgery. So it makes perfect sense. Among both the RCT as well as the registry, not a single E was attributed. Okay, what we need is long-term follow-up, and with coils will be interesting to find out because that will make things easier. Of a migraine that could potentially. And at the end, I will acknowledge all my colleagues from different. This is our Winnipeg team here, who have worked this fast and much larger team member. 100 co-authors will be there in this. And this is our division of neurosurgery in University. And this is the nurses and techs. Without their help, everything that we do there. And last but not least, my own family, my wife can do this service research work. Sitting right. Thank you so much. Questions?
how do we get the patient in whom we get this embolization since it adds an extra cost to the treatment? And in our setup, we have to justify the cost of this.
Okay. So two ways to look at it. I come from universal healthcare system where cost from that side. If the cost is not to deny a treatment which is with number of 2. That's the question I would ask ourselves. How can we this treatment give patient? Now back to the forget that when these patients are tired. And majority of us already debated, some of us don't even see this difference because they don't show up. They do look at they do suffer, they show up to the that doesn't mean that because it's not there. So the cost is much higher than what we anticipate. I'm going to actually answer your question directly. The cost, right? Which we change, how much it costs in our health. It may not directly translate to your healthcare system, but you'll at least have the answer. In my mind, if the treatment is giving you effect size of treat of 4.2, but you cannot deny this treatment really. And don't forget that here's something very interesting going on in endovascular. In 2015, ISEP came, changed how we treat angiogenesis. 2005 was ISEP. 2015 was all the endovascular trials still, and the world changed. Before that, we were exactly which patient to offer. And after that, how can you deny the endovascular to any of these? They're symptomatic, not symptomatic, fluctuating, you still do the endovascular. So I feel in the future, in coming days, what is going to happen over, we will come to this position that why would you not offer this treatment to this patient? And actually, many of you is your alumni. He's doing this. He's putting this paper together, but he's looking after what kind of surgery we, how Emma would help in those patients. And guys, this data is not complete. Is which drill patients actually benefit the most? So someone can ask that why do the criminal? It's provocative. I'm not supportive of this. We don't have a data to stand on this. I argue that why do complicated surgery? Just do a twist drill and do EMA. It's going to likely give you more effect. But I agree, the cost is a factor. We will need more to understand much to perform the cost is going to factor in. But I feel that this in the future we are going to do this, and it's quite good at many of the subdural hematomas where the patient is fluctuating, 1 millimeter thickness size. Patient is a few hours later he's asymptomatic. You may do only EMA, no surgery. But surgery will still be reserved for patients who are very symptomatic. There's no alternative to surgery there. Don't get me wrong. This could be alternative to surgery for certain patients who are like not very symptomatic, completely asymptomatic, or you don't want to do surgery. Now the patient another comorbid I remember the patient who had liver failure, kidney failure, ascites, had subdural hematoma, needed deformulation because he has a heart attack and has a subdural hematoma. What are you going to do? One is okay. This patient is not going to sleep alone. This is not a bad option, honestly speaking, in certain patient. But if the patient is doing independently functioning otherwise, you offer treatment. He is not very good option. And this could be the option. complicated, long answer, but hopefully you get the message.
As you can see, it is working in a lot of patients. If I found any predictors, so we'll know that so well, so better data.
Great question. I'm going to go to the picture so that you have only 4 patient who is not recurring. How can we 4 patient and figure out which way to those patients? So the answer is we don't know that much. We don't know what risk factors are there where the patient may still recur even after doing MRI. Is that what the question you're asking? Okay. So MRI, but did recur. We don't know. It's a pretty small number.
Data number is big, so maybe that will help us. Radiologically speaking, the more
Point. Yes. Reason why we graphic recurrence available. We don't know that. We're also putting all the data together. Trials. Analysis will all because we have more numbers to start with.
Like in the chronic acid patient who had developed some memory. In a short period of training, we have seen that those patients benefited the more. Those patients who were the more who presented with recurrence more with the embolization part.
So, graphic between corkscrew vessels or water.
Answer to that, I don't know. Look for all those radiographs prospectively. And membrane or no membrane doesn't change the rate of recurrence. This are getting rate of recurrence more range. Which is interesting. This is very, very interesting. I was not expecting huge effect size. I was because you are running the trial, so you kind of get the sense of okay, which patient is recurring or not recurring. But I was like, it looks like the trial will be positive. But this much positivity, I was not.
So, what about penetration of the liquid embolization in the patients who recurred? Was that the same as
Again, one more time.
the penetration of liquid embolization in the frontal or the parietal?
Yeah.
So, was that and how mattered? And it's along the dura, so it's not a sac or a single plane. So it goes in a very hair thin like manner. Yeah. So there's no volume to it. So maybe that could be factors in the sense which might lead us to something for the rectum.
So that's a very good question. So what essentially is the degree of does that matter? The answer is yes. So we are going to we will be reporting that as well because that was all pre-planned analysis. So this is the grading system that we had. What we said is grade 1, grade 0 is we couldn't do embolization. We had 5 patients who could not do embolization in this trial because all those 5 patients had what? The MMA was coming from the thumb to get in there and do anything bad. So that's grade 0. Grade 1 is okay, you did something to that patient. Something. So that's grade 1. What we did was, I didn't say this to you, when we do the angiogram, before and after, we run from arterial to the venous phase. Because late venous phase, if collaterals are filled, will be able to see. Okay. So this grade 1, grade 2 is when we do collaterals fill. So, and when grade 3 is no collateral filling at all. So both grade 3 we thought it was a successful embolization. And we encouraged, we encouraged to get to the grade 3 embolization. But many times we could not do that because there is a very tortuous proximally those vessels are very tortuous and we can't get to them. So in our data, the there was increased rate of recurrence when there was grade 0 and grade 1 embolization compared to grade 2 and grade 3 embolization. However, statistically, but it was 90% versus 5%. So that's significantly. You can't claim anything because p-value is not significant.
But for this, you need bilateral.
No, we don't need bilateral.
Because ECA branches can have bilateral supply.
Absolutely. That's a great point. So we only did unilateral, did not do bilateral.
I understand,
Yeah.
but when there could be a possibility, it could be retrogradely killing the dura. We see them.
Absolutely. That no, doing just unilateral MR, you get down to 4%.
Right.
So why add that additional to those patients? So for what you're saying is in recurrence, we want
to see and see sometimes in the acute phase, cSDH on the contralateral side, there will be no will be very so they might not recruit immediately, but over days and months, they might take up recruitment.
Those are very, I agree. But we don't know that information, right? We don't know that how these evolve. You have is there are in our study patients at the exact number where the hematoma actually presented as acute subdural, exactly how you were saying. You were waiting, surgeons were waiting for the patient in the ward, operating, and then it became acute or chronic, and then they operated. So it will be interesting to find out if those patients behave differently than the others. We don't have the information, but are good.
So in your study, you did unilateral.
Absolutely.
And you did only line which says NNT or bilateral.
So that was the registry.
Okay.
So this is the registry part. Where registry, in the registry, we registry with the control arm of the RC.
And you said that you so in that you obviously did.
In bilaterals, yes, we did bilateral.
So what was the time of inclusion? And you did subacute also?
Only one.
And the definition more than
50% of body.
No, but not
like only scan.
that you
we didn't look at like you look at the previous study and that you go from it.
And when there's bilateral, you do that in stages.
No, bilateral we do only in the registry. Don't get confused between the two. So there was not a single in control part. And those are the reasons why were in the registry. 50% of the patients in the registry were bilateral because they were excluded from the RCT, so they got into the registry.
Did you have patients who had a large hematoma in terms of epicenter?
Yes.
So did you find any change in the MMA? Like we could not see the MMA.
Yeah.
It was by the size of the hematoma.
We haven't seen that.
You haven't seen?
No, because if you didn't see MMA, then it must be coming from the other.
But like it suppressed, you could see that there was no way that you could.
So what I see is when you see MMA, we are not all of that on the CT. Not we don't even go to the DSA to have that on the CT angiogram. And smaller than you expect it to be. Almost invariably, it's supplied from somewhere else.
The cutoff of the diameter
of MMA.
Yeah,
we don't know that. It's that question. Yeah, so we are getting all that data, but right now we don't know the answer.
So like we have like our neurosurgeons also mentioned, we have data which say that patients who have cotton wool appearance, I think they do benefit the most from MMA and MR. So, how do you define a patient with CT angle?
No, we don't know. CT angiogram
So
will not give you-
that's right. So there is doing a re-embolization define so that this guy will work better.
But remember, like, you're not doing a diagnostic and patients to get those pictures. You're just finding that yeah, no, fair enough. So the question is, how do we know that? Because before we do it, actually.
Yeah. The other thing is, did you do embolization in patients where you find this cotton wool?
We were not looking for cotton wool appearance or retraction.
So you did that.
We
So it says that in patients who don't have cotton wool appearance, the recurrence is there. So the Swiss guys have published.
Observational study with you have to good natural history data. You have to look for control arm. Right? The control arm gives you the natural history data.
Have you seen microaneurism?
Yep. We've seen durally. Just published that.
Yeah, in that.
They must be incidental, right?
No.
Huh?
Microaneurism.
This is microaneurism.
Microaneurism.
In trauma and all you may find.
And
with
when you do
SDH
the
in trauma,
and then you know that this
the inflammation changes are.
Yeah.
We see those. Do you have any idea after embolization? 4%. No, after embolization, yeah. How many days? After within 90 days. Within 90 days. 4%.
90 days is the time frame for patient. No.
No, so 90.
Wait for more than 90 days.
Great question. So what we have data is only up to 90 days. Someone can argue that okay, patient may recur later. We don't have. We are following these patients up to 1 year. We don't.
No, I'm not saying recurrence. I'm saying that these patients, when you're saying that recurred,
Yeah,
they might resolve down the line.
well, that's different thing. So remember our primary outcome is recurrence. Patient recurred. Patient reached the primary outcome. Right? So whether they resolve later is a different issue. Right? Because if you get that the smaller subdural hematoma, if you don't operate, they resolve. Here is helping the system, and how we know it at the data from subdural hematoma at 90 days, and in MR arm, it was much smaller in the non, much smaller. The mean was 10 millimeter in the control.
Can you again?
So at 90 days, the residual hematoma in received MR mean was 11 millimeter, 4 or 5 millimeter. So we also know that what it is not only just reducing the recurrence, we are also facilitating reabsorption that you're talking. Right? So that's also involved.
Like branches, frontal and parietal, they take care of the frontal component. What happens? Do they?
So we don't have like those numbers are too small.
You don't go after the temporal branch.
We do go after that.
You go after the scoputum, but
if we can get
but
it,
the lower cranial nerves arise.
You remember I told you go to distal, wedge position. Because you go that distal. So I can show you how distal enough. And so that's the point. Like you go that distal.
Can you show
Yeah.
scoputum?
So this is where how far we go.
Then parietal.
Even if we go to some of those temporal I don't have the example for that right now. But even if we go, if catheter cannot advance the embolize. We only embolize when the microcatheter is gone back.
But branches, they're in the nerve, then they will be terminal only. So even if it will be harmful only.
We haven't seen that happen.
Yeah.
I'm just saying we haven't seen that happen, but point, like we don't want reflux to proximal.
So in all your cases, frontal, parietal, and
temporal is large enough. If it's too small, then we don't.
How commonly you get the temporal?
oh, no, not only temporal,
Like in combination.
but in a patient with temporal SDH, you get somatotemporal arteries.
If those are, then we go into that. But if those don't go up to that, exactly for the reasons you mentioned, because those are too big. Whenever we got into those, remember sometimes what happens is the parietal branch, it doesn't exist. The stematotemporal branch is to supply both. We go after those and we go distal.
And this concept of coils isn't the concept of the whole theory on which MR is based, because you are causing whatever said and done the most proximal, and it won't work because there are microangiopathy happening in the membrane. It will if you don't penetrate the bed.
Fully, very well taken. I have no comments on that except remember. So the only reason we're trying, like remember the coils that have been published, all those coils are proximal coils. No, what you do go distal and try to iterate the MMA
Yeah. Otherwise, also you do not know how much you have, and then you have decreased the flow and all. So maybe what you were talking, and that either you have now. Let's say do the super selective, you will not know what to get.
No, and this is what we did was this we did carotid artery run long
Venous phase.
Yeah.
That
late venous and late venous phase you'll start to see
okay. Retrograde.
That's what we were looking for it. So that how much residual filling is there?
Do you do a microcatheter run?
No.
CA, main
CA.
stem.
Instantly.
You use vaso-CT.
So I just showed you one picture just to we don't do it every time.
We don't need, otherwise
We don't need it.
so much radiation.
You don't need it.
Not for,
No,
not for this. Okay.
One case. These were learning to know how much we penetrate and all of that, but that's it. We never did learning purposes.
So what about in recurrent cases of both groups? Does the treatment remain
Medical, no?
surgical or
Like you said that you show that none received DEXA and Trenexa.
So medical treatment you're saying between the two?
informed surgery, not just medical?
Okay.
If a patient presents with recurrence of the group, then what about this?
So the answer is do you stand of care? Whatever you're doing right now. The moment the patient reaches the primary outcome, rest is standard of care. Trial stop. Okay? So that's how it will be did. And don't forget that there are only 4 patients in the arm which recurred. So not much can be drawn from out of those 4 patients that. And medical we left everything like when to stop the anticoagulation and not stop the anticoagulation. That was surgeons or we were the physician in charge of the patient to decide. Interfere on that. We did not interfere We did not dictate what kind of surgical intervention was done. So the majority of them were and followed by the twist drill, the smaller large cranial. So that is decided based on the clinical and the comfort of the surgeon as well.
What is the reason for twist drill to be most beneficial?
Oh, we found
But what is the reason?
the answer to that. What is the reason? Someone can argue that you amount of surgery. So am I if you patient? This could be one way to look at it. And Pant and I on this to answer exactly Amit's question. Someone can ask, then why bother complicated periodic? I don't know if that is the right answer or not, but we need more data to answer that question. Because those patients are very more patients who are getting periodic. Or someone can this information can be twisted anyway. You can say that okay, maybe twist drill is not good enough by itself.
Do you use intra-arterial lignocaine? You don't.
Lignocaine for this tooth.
Yeah, it calls.
No, it's for mainly for the purpose of keeping it less
Painful because you're killing the vascular to.
Just through microcatheter. Through microcatheter. Those patients who are doing this under constant sedation, to reduce the pain caused by the neurosurgeons.
I made a protocol years ago, 4-5 years ago for chronic SDH. A single patient was referred because bread and butter surgery.
Yeah.
And there's
No doubt about it. Actually, with your this much experience, this much of positive time in your study, did you suggest points of your patient primary EMA only without surgery? And what do you think? Will EMA replace surgery or it will remain as into surgery?
So I'm talking. You cannot say that EMA will replace. So politically speaking, I'm not supposed to say that. As I mentioned earlier, some of those are like barely symptomatic. 12 millimeter, 14 millimeter thick hematoma is not very not want to do surgery. Be the reason. You may be very tired. You are post-call. You may not want to do surgery. These things do matter, right? In real life, how you decide about what do we do. So some of those patients may go to. In our registry, we did MR without surgery. It did benefit the patient the same. But MR would replace surgery. I don't think we are anywhere close to that. Much more information should be. But yes, patients who have surgery is not indicated, MR is an option.
And any patient is different criteria. All.
That's what we are saying. That's what we are saying.
Asymptomatic?
Only if somebody we used to do like, but the problem is sometimes what we have seen were asymptomatic. So there is a 13 millimeter or 14 millimeter hematoma. Patient is asymptomatic. You follow those scan and you see there is a small acute subdural hematoma coming. Patient is still asymptomatic. Is it worth just the risk of them following without doing anything? Those are the patients surgery will help. MR will help. Maybe you want to do surgery? If the patient for surgery is not very clear, do MR.
It's more entering as well. It's more invasive. Doing the hole is just like very small hole, maybe 3-4 millimeter of the needle, and you're evacuated. That is so.
But the rectum
There is no rectum.
high. So they say that to do the membranectomy along with the
Not all patients are. Not all patients are subjected for this. Maybe only 2 or 3% of what we see. I said the biggest problem is they do not come onto the surface. So when we drain does not surface. So you have the accumulation that to study in older the membrane will bleed and they will cause the recurrence and all, right? So and one is that when we put the fluid after during the closure, so if it is not put properly, then the air will come instead of the fluid because brain has not come onto the surface. So study how much cases we have seen the brain has come to the surface. We used to say that atrophy, membrane is there, brain is not coming onto the surface. That is the recurrence, and they have pneumocephalus. So actually, in the headache is more because of all these complications than actually recurrence.
So the answer to that question, we didn't go into that much of granularity about what the brain is coming up. So that part we left to the surgeon, like how aggressive or they need. So we didn't that part at all. Can we go back and look at that information? We can.
But on CT, you will be able to, whether there's a gap in the bone in the inner table and the.
Yes, so most of it. But pressure
The fluid is not there.
yes,
Not there. Blood is not there.
pocket you can see, but those are it is there. But pressure is really pressure is exactly. So when symptoms exactly, and that's what I'm saying. Actually, the same point. Just looking on the scan doesn't mean it means to the patient as well as to surgical approach. So both are important. So we don't have that information on it, but we can definitely look at how much information, how much reduction is there. Wait a second, let me re-say this. We do have information differently. So what we did notice is the reduction in the both EMA arm and the control arm at 24 hours. Okay, so that was similar. Notice is residual at 90 days was much larger in non-EMA arm versus the EMA. So we did talk about this, that EMA not only reduces the rate of recurrence, but also expedites the rate of resolution of the hematoma.
But why not in asymptoms with more than 10 mm? You know,
Do that.
of diameter. Why?
Well, so that's the
Just because they are asymptomatic, you know.
symptomatic and very rigid.
No, but they're saying that
Not elasticity or and not. So that's a clinical decision, right? And some patients, even if they are asymptomatic and you're 2-3 scans, some increase in the you may want to operate or may want to do MR. So that's a lot of clinical nuances. I don't think we are going to answer all of those. You had a question. Yeah. We use some detachability. No, we are keeping it so super simple. These procedures are 15 minutes. So marathon might they don't pay me anything but 10 takes, okay? Because we guide get there. Marathon microcatheter, one of the 08 or required to go distal. Sometimes what happens, the of the arch or with the neck is so much that the 5 French envoy may not go through. In those cases, if we need to use a SIM guide catheter, we do EMA through that. We are made it so simple to answer your question. Maybe really more invasive than your bottle. Just joke here, but I think if you take away the cost associated with this become a very simple procedure. Diagnostic catheter. Many times we've done a diagnostic catheter. Through that we put put the marathon microcatheter and wire EMA escape.
but sometimes we find that they don't support. So what we do is we use a long sleeve. And the
In case I've used long sleeve.
No.
We've done
We have had. I'm not talking about Emma.
yeah.
We are doing embolization MD for dural ABF.
Sure, that's this is what am I saying, Amit? Single anything more than what I described to you. Not a single health.
And you didn't embolization if you could not reach the distance. Like how far was far?
The reason I want to go to which position as I showed you, that's the ideal situation. But tortuosity
It's not possible.
So what we do is inject very slowly with no reason, let it go. You know how far distal we can go through the proximal problem. But we have to go distal.
So that is what we do. We just change the this PCA and we make it 50-50 rather than 75-20. And that is how we go distal.
Yeah, so go distal. We need to have the RCT membrane data is coming up. Membrane study was using presented the data a long time back, almost 10 years back. It has not. So we don't know what's going on. So we need the RCT data to support all of this. Individually, we all have.
No. You're saying that they change the viscosity of the histoacryl.
Yeah.
Not change in onyx, which you are going to.
No, you
use particular.
You can use squid also, no?
We use
So squid
for RCT. It's
but you use squid.
yeah, we did.
So in squid you use 12?
No. Only
Why?
one patient.
Why?
Why? Someone can argue that why we use anything different when the routine thing is not.
We will have more penetration.
To give that, like I'm just saying, 18 is given.
If you achieve a bench,
if you achieve a
if I think 12 would be phenomenal.
I am not. If 12 is any better than 18, right to say. Conceptually, it makes sense, but we don't have that. If 12 is much better than 18. What exactly is a bench? So this is where the micro cannot be advanced distally yet further distal.
And no reflux.
Reflux could still be there, but it cannot. That's why like you're kind of working it into that.
You're going in and you're stuck.
Yeah, the face of the micro is on the wall of the armpit.
Snugly fitting the wall of the.
Exactly.
Listen.
Generally, if you have a very good wedge, reflux should not be there.
Should not happen. Yeah.
That means not wedge.
Yes.
There has been a.
That has been like it comes. And it depends upon how much the plug and then it blocks it back, so that can. If there is a proper wedge, it will not. It shouldn't.
So if you are taking with the mic, keep going, you take it a position where it's still not going, and if you can take a micro catheter right up to there without withdrawing the wire, that is how you can achieve the wedging, right?
Yeah, that's right. Great. Thank you. Lots of ideas I got. So much.
So we have from the OT also. There are staff. Neeraj is very supportive.
Hello.
Yeah, Neeraj.
Thank you.
As you said, they are the back.
Oh, totally.